My job today is to talk about money and the next 18 months of money and how that comes in. And to the challenge this morning, and how we're not going to talk about it today, but chapter 3 of this 3-part series is going to be sustainability. Last time we talked in detail about the quality measures and how we're collecting and measuring the program. Today we're going to advance that to how we're paid on that and really be thinking about an 18-month sprint on that. Okay? I don't want us to lose sight of the soul of what you've all been doing for so long so well. A lot of what you've done is figured out all of the pieces. And I love Kelly's analogy this morning of slowly turning the spigot or the fire hydrant on as we go, because the measures are going to start to read that. So we've got all the pieces in place, and now we're going to work toward that. Okay? So today we're going to look at some baselines, and we're going to have to time travel a little bit because you have to go back in time with quality measures. So we're going to look at where we were in December, and we're going to look at where we were in June of 2018. Okay? So a lot of the work, the recent work, is not going to show here. That's important to keep in mind. Okay? And then we're going to go ahead and think about how we're getting paid on that. Okay? Next, please. Very quick refresher. We talked about this last time. The way the IDN brings money in is very quickly, the counties help us lever down federal money. It comes to the state passes it out to the IDNs. The IDNs then have contracts with all of your organizations to do the various programs that you've got in the workforce programs. That money in 2018, 25% of it went to at-risk, meaning that that performance measurement was part of us drawing down the money. Okay? 1/4 of our money for those 2-year halves. This year we're 100% there. So everything that we have going forward to the end of the waiver is based on our performance against a set of measures. Now in the room there are about 11 organizations that are most heavily measured, but everybody that wraps around those organizations has an impact on the measurements that come through. Okay? So you may be at TLC with peer recovery, but there are measures that are going to pick up the things that you're doing to help somebody stay in recovery and not hit the emergency departments, things like that. Okay. All right, next slide, please. These are the behaviors encouraged by the measures. We went over these really much in depth last time. I won't do that again. But let's just remember that the real core of this waiver is screen broadly, do something when you find a positive screen, connect all of the folks that stood up, you cross-connect, do those multidisciplinary core team, and engage that community support fabric that we have around the healthcare, formalized healthcare system. And then there's a subtext that's been a little bit painful for many of you, is we are stepping into an era of pay for performance or capitation or value-based payment or accountable care. It's here, it's happening, it is your world now. The Medicaid waiver may be your first introduction to it, and part of our job is to prepare you for that modern future, and measurement is a big piece of that. So for those of you who have been pulling measures in the middle of the night and trying to get them into a flat file and sent off, that's been a lot of hard work, we know. But that is a capability that you have to survive in this market, and it's a capability the IDN has to have in place to be paid so that we can continue our work. All right, next. This is my 11:30 at night, like, aha moment, which is the stages of grief, a performance measure. We set off to change the world when we started this, and there was a pretty bold vision of integrated care, and it came with 49 at the time quality measures, which were roughly correlated with what we wanted to do. We did a lot of work especially in the last 11 to 12 months, your organizations did a lot of work to figure out how to suck data out of your systems to be able to report. It was heroic work, so thank you for those of you who did that work. Today you're going to get some of the metrics out of that work, and it is a known pattern that when you first do this, the first set of measures are going to be way down here. Okay, it's just part of the deal. So we're going to be at the low point today, and we'll go through denial, anger, bargaining, all of those pieces. We have to do that. But that's expected. There are tons of problems with your EHR systems. There are tons of problems with your data formats and tons of variation and all of this thing. It's just part of the deal. And the first look at the measures sets us out on a path to fix those. It's 3 kind of big steps that we will go through with you in a sprint in the next quarter. The first is to fix the data reporting. You're going to look at your data and you're going to go, that's not right. We do that. Why isn't it showing up in my measure? And we're going to trace those back with you and figure that out. Oh, look, the date format was off. Or you said yes instead of positive. Or any number of really silly things. You're going to be like, oh, we are doing this. Okay? That's going to happen first. The next thing is we're going to find out that surprised that clinicians don't put stuff in the same place as their peers. Okay? Somebody may be putting a follow-up in a diagnostic note. Somebody else will put it in a standardized field. These things are going to be in many different places, and part of this is going to be harmonizing the way clinicians chart, and part of it's going to be having the data people look in other places that they didn't think to look before. Okay? That's part of the journey. And then we get to the really good stuff, the actual stuff that you came here to do, which is all of the scientists. If you identify as a scientist of some sort, please raise your hand. Okay? You take data, you take a hypothesis, you test it, and we start doing our plan, do, check, act, or DMAIC processes, and we improve on each of these measures. Okay? That's where we want to get. We can wallow here for a long time, and lots of people do. We'll actually run out of money, so it's a little Darwinism here. So we take advantage of the support that this program has to get us out of this as fast as possible so we can get into the really good quality improvement. That's what that we hope to help you with. Okay. All right, first measure. Let me break this down the way this shows. There's a baseline. There's a how we did January to June of 18. There's a how we did as an IDN July to December. Remember, we're in this together. We're measured as an IDN on our population of 29,000 Medicaid members. Okay? This line is the target set by DHHS and the trajectory through the end of 2020. Okay? It's a really steep slope. If you were skiing that, it'd be avalanche. So we are, again, time travel with me. We're in December of 2018. And most people at December of 2018 were trickling through a couple, 4, 5, 12 assessments. You're just turning on the spigot, to Kelly's point. Okay? That's what our measures are showing. Okay? But we're going to have to turn on the spigot pretty hard to get this to work. The good news was this was anticipated in the contracts. We were in a pay for reporting period. Meaning we were paid on the fact that we could get 11 reporters to report. Okay? We had 9 reporters in by the end of June, and the final 2 sprinted in at the end of the year. So by the end of the year, we were able to be paid on this measure, which is great. This measure, these will change over time, but right now, these measures were worth about 12% of our revenue. In the first 6 months and about 5% of our revenue in the second 2 months. And we were able to draw that down. Okay. I'm going to show you de-identified, and this will probably be the last time we de-identify because we're going to really ask you all to come to transparency, full transparency when we do this in the future. But this next slide shows where we are as partners. Now, there are 11 reporters, and some of them are split into multiple sites. But we have only a few really pulling hard as of December of 2018. Okay? So one of the things here is there are those of you that just had piloted are starting to ramp up now, and that's going to be really key for us to go. The good news is some of our reporters are getting 100% of their CCSAs or their core standardized assessments going through. And then we've got, by the end, we had about 4 that are showing up with enough volume to be on this radar. We had some data anomalies, so some organizations that were doing this really well are not showing up. So we know that that's part of the problem.
Mark, when you say 100%, are you talking 100% of those who are eligible actually completed it? Or what's the?
Yep, so a Medicaid member comes through the doorway of that organization, and it's not an acute event, and so it's a regular appointment, and that person fills out a full screen or a full assessment, or in some cases, if they're a community mental health center or like a Phoenix House, they're getting accompanied assessment with somebody going through a full DLA-20 and things like that. So the organizations that have an accompanied model where they're doing the assessment have much higher scores. Those that are doing this as a screen in the waiting room, that's largely a new process, and they're on the ramp to catch up. Okay. All right, next one, please. This is our Assess 2 measure. It is measuring, remember, a core idea of the waiver is to screen broadly and to follow up when you find a positive. The measures themselves check in on follow-ups only in a few areas. One is depression screen, and the second is depression and suicide are together. The second is substance use. Okay? This one squishes together depression and substance use. We're doing pretty well. We're up here on the first set and up here in the second half of 2018. The target goes up to roughly 80% by the end of the waiver. Okay? That's the good news. The other good news here is that this is pay for reporting again. So we're able to hit this for the year, and we're able to be paid for 2018 on this measure. The kind of medium news is the denominators here were pretty low, meaning the number of depression screens being done wasn't very high. So as that goes up, this number is going to swing all over the place. Okay? It may go up, it may go way down. We don't know yet. So we can't trust this as, hey, we're in great shape. Some people had 100% on 2, like a denominator and a numerator of 2. So we know that could go to 10 in a second. Okay, next one, please. The other good thing is that's 550 follow-ups last year on depression screens. That's really great. Okay, so a lot more organizations are reporting on this one. So a lot more people are pulling on this measure and bringing it up for us. Next one, please. On substance use, we had 70 follow-ups on positive substance misuse screens. So that's great. And depression screening is a little bit more mature than substance use screening. We're finding one leads the other at this point. Okay. Next one, please. Our Assess 4 measure is on smoking and tobacco cessation screening. And we're down here in the 15% range. The target goes from 40 up to roughly 80% on this one. So this is another one that has a pretty steep, all 3 of these have pretty steep targets. We're doing well. This was a pay for reporting to get all of our reporters by the end of 2018. And we successfully did that in both periods of 2018. So we were paid in full for this particular measure. Okay. All right. The next set of measures, so this set of measures we control because you're gathering clinical information, and so the lag isn't as great. We still have a lag of a few months. We're now going to have to go all the way back to, oh, sorry, I should finish this first. 740 follow-ups for smoking screens last year. So we're doing pretty well there. And as you can see, a lot of people reporting on smoking. All right. The next set of measures are claims-based. So we have to go back in the time machine all the way to June 2018 now. Okay. We don't have the second half of the year yet, so we're a little further back. The first one is about frequent emergency department use within the behavioral health population. This is a target that goes down. We're trying to keep under. And right now we are, as an IDN, quite a bit below the target for this one. We're doing really well. And so for the first half of 2018, we're able to be paid on this one. It was worth a lot of money, too. It's 18% of our total revenue for that particular period. There's a lot of focus on ED utilization in our payment. Next one, please. This next one is avoidable, potentially avoidable emergency department visits. Again, we're supposed to draw this down over time. And again, we performed really well on this particular measure and are paid in full. This one was also worth almost 19% of our revenue for that period. And follow-ups. Follow-ups for mental health diagnosis within 7 days. We squeaked in. Okay, we're right above the target on this one, and we're doing okay on 7-day follow-ups. That means somebody that comes out of a hospital with a particular mental health diagnosis presents with a behavioral health clinician within 7 days. This one we're gonna have to. It's worth a lot, 17% of our revenue, but we're a little bit close to the line on it. Okay, next one, please. Similar to that measure, there's a 30-day follow-up. Okay, and the 30 days we're not doing as well. We missed this one, and this one was worth roughly 17% of our revenue. Okay. We had quite a bit of a fall off from our baseline that had been established, so we've got some catching up to do on this one. And then I think there's only one left. Opioid prescribing. This is where we had a fairly good baseline, and our baseline was pretty well above or ahead of the other IDNs, but our first reporting period went up quite a bit, up to almost 16%. So our opioid prescribing right now is a miss for the first half of 2018. Okay. All right. Now to the math. Okay. So I'll take you through this. This is likely to change over time. There are factors in the state with the reduction of funding that may have this all change, and that's okay. But right now, each one of these measures has a weight to them, and that weight is applied to the amount of money we bring in. Every 6 months, this is variable, but every 6 months we bring in a little over $1 million to the IDN and then disperse it. So just to make the numbers really easy, I use $1 million as the example here. It moves around, and that's also hard to predict, so I can't say it's exactly this. But in this case, if we assume from January to June of 2018 that there was $1 million available, remember 1/4 of that was at risk, so there's a pot of $250,000 that we have the opportunity to go after. Okay, 58% of it, or about $145,000, we earned. About $105,000 we did not earn, but we were able to recoup. We were able to catch up because that's part of the mechanics and the money. So all in all, in that first part of the period, we were able to bring in the full $250,000 to the IDN. Cash is still not here. That's still part of the lag that comes with this program, but that's how it's calculated. The next part, just I drew this out just so you could share in some of the lag and some of the uncertainty that comes with this. So for the next period of July through December, same thing, we have about 250,000 available to us. Only about 10% of that is known today as earned, okay? The remaining almost 90% is in an unknown bucket, meaning the data's not in yet, or the measures are full year measures that, like the care measure that you're all working on, or the data isn't in yet. So we're having to project ahead with that level of uncertainty. We're not sure how much of that we'll bring in, okay? So there's still 250,000 available. We're going to obviously keep pushing on these measures as we go. All right, so that was the math lesson part of this, but that's our world, and this 250 quadruples as of 2019. So we're all of our revenue from now on goes through this type of a formula. So that's how. Maybe I'll just say it one more time. That's kind of the counties help us lever down federal money. It goes to the state. The state has a set of metrics and targets that we need to hit. Each metric is worth a different amount of money. We get as much from that as we can collectively as an IDN, and then it's dispersed through the grants and the contracts that you all have. Okay, and we hope to get out of the grief curve as quickly as we can and get to a place where we're performing really well on these and can optimize this funding stream through the end of 2020. So. With that, we're way ahead of schedule, so if there are any questions, we can go through them, and I'm going to draw heavily on other experts in the room as well. Jamie has been leading a lot of the work. She's in the back here. A lot of the implementation work to get you all there and knows the measures intimately. So if you've got questions for either of us, please let us know. Yes?
I wanted to ask, with the measures on following up with after an ED visit with a mental health diagnosis, what kinds of denominators are you seeing there?
I'll have to get back to you with the actual denominators. They're at a high level, they're really low, and they're really dispersed. And we started thinking as a team right away, do we go after this? Because the people that are, the hospitals that are discharging to us are not, most of them aren't in this room. It's a Scutney, it's Brattleboro, it's Parkland, it's Portsmouth. So we don't control a big piece of the intervention. And that makes it harder for us. Luckily, a lot of our work has been with New Hampshire Hospital. That's one of the biggest, and with Mary Hitchcock. So between those two, we do have quite a bit of control over that piece of the measure. The others, we're going to be in this land of we're being measured on something where we don't necessarily have control of it's like the sending district of the school, right? We don't know who's coming to us or even who's being assigned to us. If somebody comes out of Portsmouth and decides to live in Unity, and they don't show up, we might just not even know about them until about 10 months later. That's a great question, but we'll keep chasing that one down. Yes, Sue Ellen.
So a big piece of the efforts even at West Central has been to try to do a lot of this gathering of the data electronically. Part of the slow process and that ramping up has been because a lot of it was just chart reviews, and that does not work as well, and it's also very time consuming. So as the measures were coming out, it takes a while to change these electronic medical records and build in this stuff, excuse me, electronically, so that we don't have people doing chart reviews for lengthy periods of time. And so we're now just getting where the measures that we're reporting for the IDN are primarily electronic. So hopefully that will improve the data, and other people are doing the same, because you just can't keep up with it if you're just doing chart reviews.
Thank you. Was everybody able to hear Sue Ellen? Okay. Thank you. Yeah, and again, it's our new world. So you may have a single payer or two payers that are asking for this, and then you throw MIPS on, and then you throw, each of the privates start to ask for this. It is our world now. So you do need to be able to scale beyond just chart review. Those that have been in the accountable care world for a while, those big programs they will have most of it electronically fed and generated, and then they use chart review on the margins where they're really close to the line. So they'll be like, oh my gosh, we are really at risk of losing on this measure, and it's worth X tens of thousands of dollars. Let's throw some extra chart review in a very targeted way. So it's not their whole world, it's just very, 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 very targeted that way.
Mark, when you mentioned that you're going to be getting more transparent in what you're disclosing, what is going to change in what we just saw with as you present the numbers?
Most organizations have said it's okay to share my data with us up here, like yours. So it would be that slide where I showed those bars. You would see that Valley was the red bar. For instance, that's what we're saying. It takes a little bit of a leap of trust because our numbers in many cases are very low, but to trust the room and to say we're going to learn a lot better if we know Phoenix House. I'm sorry, Phoenix isn't here, but Phoenix House's numbers are off the charts. So what is it about the Phoenix House model that we can all learn from? So that's what the dream kind of approach to quality improvement as a group is, when you can show everybody stuff and be okay with trusting everybody in the room. That's what we'd like to get to. We wanted to ask that courtesy one more time before we threw everybody's up. We have about half the organization have given that. And maybe a great thing would be if you just let me know by the end of the day, or anybody on the IDN staff, that you're okay with having your numbers up there. Sue Ellen, I know you've already said that for us. All of the Dartmouth-Hitchcock system has said that's okay. There's a few unknowns like Monadnock and New London, Newport, that I would love to know if you're ready to do that. Okay. So we'll reach out and ask that. All right, any other questions? Yes,
Mark, first of all, thank you. This was so understandable, and these are really complicated math and all that, so thank you for making it simple. Getting back to the transparency question, I don't think since we get paid as an IDN, it's like, we don't have West Central getting a certain payment and Cheshire getting a certain payment. We get paid as Region 1 IDN. And I don't think we can do this work without everyone agreeing to transparently look at each other's performance. Because we only have 18 months, 20 months left of this program. If Phoenix House is hitting it out of the ballpark, we need to know now what Phoenix House is doing. If it's a practice that is generalizable, it might not be, but I'm almost worried about like giving people options not to share. We're all going to get hurt if we can't all work together to improve. So I don't know, is there anything that we can do to advocate for partners who are concerned about sharing?
Thank you, because this is an area where I feel needs to be brought back and tweaked, and it's the smoking question. So the smoking question, my understanding is that when it's screened, and say it's screened positive, the intervention has to be documented on the exact same day to count. In our world, someone will come in and they will be screened, but then treatment does not start until another period of time. So we're not able to get credit, if you will, to get a positive on that particular screen. Whereas someone else's system, say, they're going to see their primary care doctor, they get screened that day, then they have that appointment with their primary care doctor, they will get, the credit for that. So that, to me, is a question that I'd like to see adjusted, because MIPS at the CMS level will, as long as the intervention is within a certain period of time, we get credit for that. So there's an area that I think, Phoenix House may be an example, we're an example, we're falling out. Does that make sense?
Yeah, but I think that's a great discussion that we need for us to have as a group and learn collaboratively.
Yep.
And I don't know how we can, the way I get around that tobacco is it's counseling. It doesn't mean that the counseling is the intervention. So if you smoke, I'm recommending and working with you to identify, when would you be ready for quitting? That's an intervention. That is the intervention. You did the counseling. So it may, thank God for, or curse CMS. There are ways to work through these measures, but those are the discussions we need to have.
Right.
Yeah.
Because some of this stuff, if we do talk about it, we can fix it.
Yes, exactly.
That's great. So to flip Sally's question over, maybe if you have major reservations about publicly showing your stuff, please talk to us, and that will help us understand if it is sticky. I'll go to Dennis first and then back to here, if that's okay.
I was just going to say that. As we build a community to work together to solve these problems, I think your question is really important, because in essence, it's much like the people we're working with. Why do they want to protect their information? We don't have a society that's very good about how we share people's information and how we may or may not expose someone. So I think, what I hear Mark saying, and what I want us to do as we start to really build a community, it is about trust. And a provider, whoever it may be, I'm sure they have concerns about what that may mean, and does that expose our organization in a way that makes us feel vulnerable. And so I think we have to be receptive to an understanding of what they may be saying, and that's what I think what you're getting at is let's find out what the barrier is to why they may not be doing that, because internally an organization may have a really good reason to say, I'm worried about this. So I just want to be receptive to that. I don't want us to feel like, come on everyone, let's go, instead of saying, what may be the barrier, what do we have to pay attention to?
Thank you, Dennis. We'll go over here.
Mark, can you help me understand things? I'm a little confused. Are we trying to get all the providers in the region to do all the screenings that are supposed to be done? Or are we trying to get every Medicaid consumer screened for the right stuff by somebody somewhere along the way?
The latter.
The latter.
Yeah, that's the problem. Because we don't know where everyone goes, right?
Right, so it's important that Charlie gets screened for all the stuff Charlie's supposed to get screened on, whether I do it or somebody else does it along the way, or somebody else asks a question about smoking, right? So the important thing is for every consumer, Medicaid consumer, to be screened by somebody somewhere.
That's right. Which begs the question. It begs the worrisome down the street question, further down this, which is the duplication and the annoyance of the duplication. But right now, our numbers are not indicating that's happening yet. So I think we've kicked that stone a little further. Right now, we are rewarded if somebody gets them, and way back, I don't know if you remember this, those of you who are 2.5 years ago, we looked at the numbers that the state provided us at first, and it was clear that the majority of the Medicaid population was not presenting anywhere. So we knew back then that if you were lucky enough to see a Medicaid member somewhere, that was probably the opportunity to screen. So it's kind of built in with this measure. It's based on the person and the region serving the person. It's not based on individuals. When we present, I may be extrapolating more from your question than you intended, but when we present your numbers, there are some organizations that are going to say, my numbers are really low here, but that's okay because I'm part of my intervention is to get them over to this organization, and because I know they're going to pick them up here, or vice versa. There's some of those unique cases. For instance, with some of the primary care screenings, we're not expecting lipid control to come from many of your organizations, but we are all on the hook to trying to get people that are deeply medically homed in one place and never get primary care, similar to what you're doing with the co-location model, over to a place where they can get that kind of treatment. Okay. All right. Oh, Stephanie, I was going to. Okay.
I just wanted to respond to the smoking measure. A CCSA is not completed when the patient fills out the form. That's not the date that we are intending you to look at it. We consider a CCSA completed when the physician or behavioral health clinician, somebody, goes over those with the client at an appointment, the scheduled appointment. So if it's in your processes for at intake, your med assistant asks these questions. If you put that date on it, that's the date that MAHEC is going to read it. But if you put the date of the appointment that the physician is reviewing it and having that discussion, then you meet the metric.
Okay.
Thank you. Eileen?
So a couple of things I want to piggyback on what Scott said earlier, which is I do agree that I think it's important that we are transparent in our data collection. And again, I don't think it's about sort of calling out those who are low, but really recognizing those who are high and what practice patterns do they have that we can all learn from to improve what we're doing. And the only way we're going to know that is by knowing who is doing what well. I think the other thing is, as you talk, as Phil brought up his question around what are we capturing, is if we know right now duplication is not an issue because our numbers are low, now is really a time to figure out a system of how we ensure that we never get to that point. So as we are starting to begin to do these assessments, now we need to create the system of knowing. So if Charlie goes in to see Jen, and she can go into pre-manage or something that says, hey, you haven't had your screening yet, I'm going to do it, and then 2 days later, Charlie comes to see me, I can go into that same system and go, you got your screening with Jen, I don't need to do it, and we do other things. So I don't know if that's part of what you're sort of trying to put together, but I think now is the time for us to really figure that out.
Yeah, and I think we've got some solutions for it, but they take energy away from the primary mission. So we've been operating with, let's solve that one a little bit later, just because our primary challenges, those are some high targets to hit. But I appreciate you pushing us. It is the appropriate time to anticipate that. So, Lisa.
I just wanted to, so I'm Gloria from IDM4, so I'm different region. But what I wanted to say was we're here because we're interested in what it's a demonstration waiver, and we're interested in what other people are doing because it helps and supports the partners that we have in our region. And so we appreciate the fact that they're willing to share data with us and we're willing to share the same. And what I would tell you is that our performances are similar. We have some measures that we met that you didn't meet and some that you met that we did not, as we look at all different data. But we, as IDANS, collaborate together to share that information. We don't judge on who's doing better than the other, more judging on more finding the ability to find the ones that are successful in one area and helping to move that forward. So if you're not doing good in one area, I think it's important that you share that data because our role here is to try to bring better things to all of the partners. So Mark, thank you for sharing your data with us, and we're happy to share our data with you.
Thank you. And you already have. We've been stealing your approach to event notification. So, yes. Oh, I'm sorry.
Yeah, I just wanted to make one point, and that is, while it's important to be, the transparency and the data, there may be a first step, and that is how does each organization understand their own data? You mentioned how, entering one thing could be in many different places, and right now the data that you're seeing may have, something to do with varied workflows and processes and systems. So the data may not be measuring exactly what you think it's measuring at this point.
Right.
So like the first step is the workflow and having the consistency so you can capture it.
Yes, thank you. Yeah, it's certainly the case. We know that's the case. So thank you. And maybe have you be our last question, then we'll have our break.
Well, it's not really a question.
Okay.
And it's probably going to be a very favorable comment, but I'm really struggling with, as Sally mentioned, giving the choice, because at the end of the day, these are federal taxpayer dollars that are funding this whole thing. There is a tremendous amount of money on the table. Each one of these organizations, all of our organizations, and I'm saying this more as a community member versus being tied to an organization, all of the organizations in one way or another, when they're getting federal and state money, have to report what's going on. That is standard. So to take an initiative with such an amount of money on the table and say, well, if you really don't, or if you don't, I understand the breaking down barriers, and I was really glad to hear what he had to say over there, because right off the bat, as soon as Sally said it, I'm like, everybody should be reporting. End of story. This is taxpayer dollars. We need to be showing in each organization the amount of money that you got, the amount of progress. If you've had challenges, there's nothing wrong with challenges. You're moving forward to something. But at the end of the day, we have to be able to show to the state, to the feds, to any taxpayer across the country, because really somebody in California may have a penny in this process. And we should be very transparent across the board and say, this is what we're using with that money.
Okay, thank you for that. Thank you for that challenge as well. I think my guess is we're probably no, and I mean that. I think we need to have a community where we can say hard things. I think if we are a mature group, I think if we polled right now, we're probably there. So what I would love to hear is if anybody has any serious concerns about it, they come to see us in a within the next couple of days. And if not, we will proceed with that.
We'll do our due diligence to go to all of our partners who may not be represented today, because I think there are some key ones that are not represented that may have different feelings, but we will definitely take this sentiment back, and we share the same intention.
Great. Thank you.
Sure.